as I was afraid this would happen, I didn't not hit the record button, and Cleo kindly reminded me that I should do that. So again, we're now recording, so we don't miss anything of the interesting interactions we're about to have. So again, thanks to our school's leadership and colleagues who supported us along the way. The third important contributor to Rutgers initiative is Rutgers Global, which is the unit on campus that supports and facilitates international collaborations across the world with institutions across the world. Our initiative's overarching objective, if you will, is to advance health communication, research, education, and practice across the health professions, both in Greece and the US. I'll skip kind of an introduction to the school and our department. You can find that all on the web, obviously. But I should add that we're very excited to be working with HMU as one of our key institutional partners in the context of IAPP Greece, and for many reasons. I mean, we share a common interest, similar questions we care about, despite being in very different places in the world. They've been committed to creating international partnerships and feeding them, if you will, and helping them grow. And they've been doing this for quite some time, so they have the know-how. Of course, on a lighter note, it doesn't hurt that they're in Crete, and we hope that one day we'll be able to visit, and we hope that they will visit us one day as well. So at HMU, we're working very closely with the departments in the School of Health Sciences. It's the Department of Dietetics, Nursing, and Social Work. And as one of our joint activities, this e-Symposium series is designed with several goals in mind. And so one is to address pressing health-related issues that populations and communities across both the US and Greece are facing. This includes discrimination in healthcare settings and health disparities, which is the broad topic of today's event. And of course, we could dedicate many sessions to these topics, and maybe also separate discrimination in healthcare and health disparities as well, though they're clearly related. Different populations are affected in our two countries by these phenomena, and the factors that contribute to them may be different. But we can still stand to learn from each other about how we investigate these problems and how we tackle these difficult but not intractable problems. We can learn from what interventions work, what policies work, and how to accomplish change at these levels when this is necessary. So today's event is just the first step in the direction of developing our understanding of these issues in both countries, and talking about what we might do moving forward in the direction of eliminating both discrimination in healthcare settings and, of course, health disparities. So in this spirit, today's event and other activities are designed to showcase faculty research in areas related to health that we care about and identify sort of research questions that we might pursue together. We also want to provide students and our broader academic communities an opportunity to get to know each other a bit better and get to know what we are doing, and invite them to join us if they see a connection to their own work. Finally, we want to sort of create this larger kind of public forum to discuss issues that are salient to health communication, and health professionals, researchers, educators, academics, obviously, and policymakers in Greece and the US. So we want the questions in our discussion that will follow the presentations to help push the conversation, force us to consider what we might need, what we need to do next to more effectively address health disparities. So at this point, I'm going to pass the mic to Professor Petridis for an introduction, and then we'll get on with our presentations. Costa, I see you there. You can unmute yourself and go ahead.
Okay, so thank you very much, Matthew. First of all, I would like to congratulate my colleague, Cleo, Kutra, and yourself for the hard work in order to organize this event, and also all the participants that they will contribute in order to flourish and empower this kind of this collaboration. I don't know, I have prepared a short presentation, but I suspect that I can skip this, this presentation. And I would like to tell you that for Hellenic Mediterranean University, the rector in the International Relations Office, the collaboration with US and particularly with prestigious institutions like Rutgers is a priority. Regarding the Hellenic, the Greek government, every 2 weeks they call us to check out, what is the progress regarding our collaboration with US universities. And I'm flattered that I have colleagues like Cleo and departments like all this, the Department of Social Work, the dietetics, and also the nursing, that they are working so hard in order to support all this effort and contribute to the progress of the university. From our point of view and my perspective, I'm an associate. First of all, let me introduce. My name is Konstantinos Petridis. I forgot this. I'm an associate professor in physics. My PhD is in laser physics, so I'm a little bit jealous of that this meeting does not happen within the framework of nanotechnology, photonics, but I'm pretty sure that we are going to work very close, and we are going to make the progress following small steps as this one in order to extend our collaboration also in other topics. From our point of view, and what Matthew has mentioned, we have a strong experience in order to organize and organize international events, organize international programs, educational programs, colloquia, talks, summer schools in Crete. Of course, this is the island is very beautiful, and this helps a lot. Just before an hour, we have received an invitation from the University of Cambridge to organize a similar summer school that we envision to organize also with Rutgers. So I think that we are in good hands regarding the this topic and this theme with Cleo, on behalf of the International Relations Office, and we are looking forward to welcoming all of you, your students, the scholars, in order to organize face-to-face, but of course we can start from online events like this one, to organize educational meetings, educational programs for our student, for your student. And I'm looking forward for this collaboration. And from the International Relations Office, you are going to have the whole support. I mean, this is like a priority and a commitment. And I would like to thank you very much for this opportunity. Thank you, Matthew and Cleo, for the hard work.
Thank you, Costa. Okay, so after that, we can begin with our presentation. So we have four speakers, two from each of our institutions. As we sort of discussed earlier, we're going to start with Maria Papadaki from HMU, and I'm going to turn the mic over to Cleo to give us a brief intro to Maria as Maria sets up her presentation. Cleo?
Good evening to all, good morning. Dr. Maria Papadakaki is an assistant professor at the Department of Social Work, Faculty of Health Sciences and Welfare at the Hellenic Mediterranean University. He has been elected at the position of the Director of the Laboratory of Health and Road Safety since 2016. Maria serves the position also of the President of Injury Prevention and Safety Promotion of the European Association of Public Health since 2020. He has been teaching in 3 master's degree courses offered by the Faculty of Medicine, University of Crete. He has worked as project coordinator at international level and has involved in several research projects on EU and national level. Maria has a rich authorship, primarily on primary health care, sexual health, and intimate relationships and immigrant health. The floor is Maria. We're all ears to hear you, Maria.
Okay, thank you very much. I'm very flattered with the introduction. Thank you very much also to all the organizers, Dr. Matsagani, Dr. Petridi, Dr. Kutra. So my topic is about people living in severe poverty in Greece. I have to say that probably most of you know, I don't know how much you know in US, but in Greece, we have experienced a very serious financial crisis for more than a decade. And this has impacted a large percentage of our population. And this is why we are talking today about extreme poverty in Greece. So okay, I have to press the button. What is the situation in Greece? What was the situation because of the crisis? Was a huge unemployment, reaching even 60% in women and in certain population groups. Many uninsured people due to lack of employment, and poverty. This is poverty bringing a lot of other problems like homelessness, poor people, substance abuse, a huge rise in family violence and other issues that the Greek family had to deal with. Besides what people had to deal with, it was a very new situation for our services in Greece, because for example, we have a social services department in local municipalities, and those services had to deal with many problems with multi-problematic families, and all this was had to be dealt with by few people, because our services are understaffed. And this generated a lot of needs in the population and new programs. So it was so unprecedented to see social groceries, social pharmacies, and many other new programs and organizations offering support to those people in need. This was a real new situation for our social workers staffing the social departments of the municipalities. Under this situation, it was a new thing for us, very, very new, to see, to offer material support to people. We were used to financial benefits, but these financial benefits turn into material support. So for the first time, we saw local municipalities distributing products to people in need, products like personal hygiene products or food, clothes, and things like that. And it was a new task for our social workers, who, this was not their role, but they had to do it in local municipalities. And those money were given by the European social funds, by the European Commission. They gave it to the regional authorities at the various regions of Greece. And those regions had to prepare to build partnerships, to build partnerships with local partners like municipalities, NGOs, and things like that. So through these partnerships, they distributed material to those who were beneficiaries, to the members of those partners. Based on this network, this program started and offered material to, as you see, 18,000 people as beneficiaries, serving as beneficiaries. Imagine that these people had, for example, approximately an income of 200 or 250 euro per month. So the criteria to become a beneficiary were very strict, and still are very strict, because this program is still running. So all these people were getting material support, and with material support, the regional authorities invited us, the universities, to offer psychosocial support, because they realized that material support is not enough for these people to survive, because they had multiple problems. And this is where we came as a university, and we undertook this task to offer this psychosocial support to all the region of Crete for those 18,000 beneficiaries being assisted by the Cretan authorities. So where we started, first of all, we ran this survey. And why this survey is so important, someone would ask, because usually up to that moment that we appeared, these people were just given a bag with products, nothing more. There was not personal contact with them, not face-to-face contact and a professional, empathetic eye on them. So those people got the material and left without anyone asking them what they need, who they are, and all these things. And this is where we came, and we approached approximately 800 people out of these families, out of these people being served by those services. And we try to realize what they need. As you see, we ask them who they are, what are their socio-demographic characteristics, occupational, housing, living condition, their health, mental health, and various other things. We had a sample of men and women, and most of them were married, low educated. 1/3 of them was low educated, and they had a mean age of 43 years. So some selective information is that their mean unemployment was 4.2 years. So they had a long unemployment period. And those who were unemployed, those who were employed, usually were employed in occasional occupations. So nothing stable. And you can imagine their uncertainty and instability generally. Many of them had a chronic disease. So you can imagine unemployment, poverty, and also chronic disease, multiple problematic situations. And as you see in some prefecture of Crete, we had a very huge certifications of disability. So they had a certified disability, also 6 out of 10 in some prefectures. We had the 5%, we wanted to know how many of them had also problems with alcohol, because this was on a race. And we realized that 5% of them had severe alcohol problems, not just how many glasses of alcohol do you consume, but how many people have realized that you cannot deal with daily circumstances because of alcohol. And we had the 5% of them facing very serious situation with alcohol. We also had the 20% of people totally lacking social support. That means they had not trusting people around them. They had no people to support them in daily practical issues, such as keep an eye on my child while I have to go somewhere, or could you please help me because I'm sick and I cannot do some daily routine things and things like that. So 12% was totally dependent on services, lacking any trusting person around them. Besides that, we had many individuals facing mental health issues, and this is a serious problem because 1 in every 2 of them had symptoms of depression, with very good and reliable tools being measured. So we realized that many of them had problems, but also the most important is that 1 in every 4 had mild symptoms of depression. This is very serious because those mild problems are not very clear, and you can easily miss them, and may become greater without realizing it. We also had the 40% of them facing anxiety disorder, and we had also 1 in every 10 people having severe anxiety problems. And
3 minutes remaining.
Thank you very much. We had also many, you will see that the distribution of these people around Crete is very special also, but I didn't include such evidence because it's very detailed. You can see that the people that are not in urban places face and are in more remote areas face more problems with mental health status, and this is a very interesting information. So what we did with these people, we realized that they have multiple needs, and we didn't stop there. We introduced some brief interventions. We offered individual counseling to them, and 80 people received facing multiple and complex problems, biopsychosocial problems. We assisted them by developing a group, a unit, a special unit with many professionals, such as doctors and psychologists, social workers, to support either in face-to-face or by distance our professionals at remote areas who needed help with very special problematic and multi-problematic situations. And you see here how many problems each family faced. Each family had at least 3 problems of various problems, and also needed support from at least two different agencies. So this was not easily manageable for one professional at a local setting. We offered group counseling, and most importantly for parents. We had severe parenting problems, parents not being able to control their children, not being able to handle their bad habits, and not being able to control their children from being delinquent, for example, and other issues. So many of them were supported through group counseling, and we offered this counseling in 9 community settings. Finally, we didn't want to lose anyone, so we introduced interactive workshops at local communities, and we had 11 such workshops open to 11 different local communities.
You have 1 minute remaining.
1 minute to raise awareness in the community about mental health problems. And we realized that there are many problems in the community among the poor. And just closing with this slide, which are the recommendations that we end up with this first part of the project, which is that we need to systematically collect information about these people, because otherwise we cannot follow up with their needs. We cannot identify their needs in order to improve our efforts to support them. We need integrated family-focused care. We cannot see people individually. Those people are part of a system, of the family system, and those families face at least 3 problems, either with occupation, health, mental health, parenting, financial, so many problems that are not being handled individually. So we also need to do things, more efforts about early identification of mental health problems in social care settings. You see that we need to introduce screening tools, screening procedures to find them early in local settings, and also to increase our capacity to offer more staff and more equipment to those people who are called social workers and need support to deal with this multiple vulnerability and multi-discrimination of people. Finally, closing with this, we need also, since we are understaffed and since we are under staff shortage, we need to empower carers, family carers. Those people can help deal with all these problems, and we need them to be trained, to be well equipped, and first of all, emotionally supported to keep on with supporting their own people. So thank you very much. That was from me. I was in time, I think.
Perfect, thank you.
Thank you, Maria, for the presentation. I think we'll have Riva give us a brief introduction to Lois Roxon, who will be presenting next. And then as Lois sets up her presentation, and we'll take questions for all of our presenters at the end.
It is a pleasure to introduce Dr. Lois Roxon, who is the program director of our Rutgers School of Health Professions Master of Science in Diagnostic Cytopathology program. She completed her PhD in Urban Health Systems as a joint degree with the Rutgers School of Nursing, New Jersey Institute of Technology, School of Architecture, and Rutgers Graduate School, Newark. Her primary research interest is in cancer health disparities among immigrant groups from the Caribbean and Central America. Her dissertation research focused just on that and examined cancer screening among immigrant women from Central America who resided in urbanized spaces. Dr. Roxon has published her research on cancer screening among people in New Jersey with mental health disorders and has several scholarly activities related to her efforts in cytopathology education and practice. She is a member of the Cancer Institute of New Jersey Center for Cancer Health Equity and various cytopathology organizations. And without further ado, it is really a pleasure to introduce Dr. Lois Roxon, a dear colleague.
Good morning. First, I'd like to thank Dr. Masaganis and Dr. Rivatagra-Decker for the invitation to present at this event. So as Dr. Rivatagra-Decker mentioned, I'm a cytotechnologist and an educator of cytotechnologists. We are professionals involved in cancer diagnosis. The practice of cytotechnology has a direct connection with you, my Greek colleagues, as it was founded by one of Greece's most famous sons, Dr. George Papanikolaou, the founder of the Pap test, who is considered the father of my profession. And so I'm an immigrant. My family and I came to the United States from the Caribbean in the early 1980s. We came for healthcare reasons. We couldn't get certain types of healthcare in the Caribbean. And so I think that all research is kind of rooted in your personal experience. And so I've had this kind of really vested interest in the healthcare of folks like myself, immigrants to this society. And so it's really my pleasure to share with you a little bit about my work that examines cancer screening among a unique group of immigrant women living here in the United States, the Garifuna. So let's start by talking a little bit about the underlying problem, which we all know is cancer. Worldwide, there are about 14 million cases of cancer annually, lung, breast, and gastrointestinal cancers being the most common. Here in the United States, we have about 600,000 deaths from the disease. And over the next 20 years, cancer is expected to explode in developing countries such as those that exist in the Caribbean Basin and Central America. In those parts of the world, the cancers that predominate are breast, cervical, and colorectal cancers. So we all know that the early detection of cancer through screening is known to reduce mortality and morbidity from the disease. Here in the United States, we have some cancer screening guideline that comes from a body called the United States Preventative Services Task Force. And this task force makes recommendation for cancer screening. So here you can see overall some of the cancer screening guidelines. And these three cancers are the ones that I'm particularly interested in. Cervical cancer, it is recommended that women aged 21 to 65 years get screened with Pap tests and human papillomavirus testing. For colorectal cancer, men and women 50 to 75 years with fecal occult blood testing and colonoscopy, and women over the age of 50 that they get mammograms on a biannual basis. So if you look at the cancer screening practices of immigrants in the US overall, we'll see that, or I should start by saying here in the US overall, the cancer screening rates for cervical cancer is approximately 80% among women. 72% of women do get breast cancers at screening that follows the recommended guidelines. And about 58% of both men and women get screened for colorectal cancer, again, following the USTPF guidelines. If you look at cancer screening among various immigrant groups to the United States, you'll see that there is a range of cancer screening practices. Cervical cancer practices, for example, in some populations, the screening rates are as low as 6%, whereas in other populations, it is as high as 94%. And breast cancer and colorectal cancer follows this similar kind of range in screening practices. When you look at the reasons associated with cancer screening, we see positive associations with increased screening and acculturation and length of time since migration to the US. We also see positive association with screening related to certain cultural beliefs. And of course, folks that come from higher socioeconomic status also have increased cancer screening rates for the three cancer types. So again, my research interest is in immigrants from the Caribbean Basin like myself. The Pew Research Center and the US Census Bureau data shows that since 1980, which is actually when I came to the United States, the population of Black immigrants to the United States has doubled, or I should say, has increased by fourfold. By 2060, it is expected that 16% of the Black population here in the United States will be comprised of Black immigrants. Here in the New York City metropolitan area where I live and do my research, Black immigrants account for about 28% of the Black population. These folks are coming from countries such as Jamaica, where I'm from, Haiti, and also increasingly from sub-Saharan African countries such as Ghana and Nigeria. When you look at the literature overall, there is a positive of literature on the health behaviors of Black immigrants. And when you look at cancer screening among these various Black immigrants, the literature is really, really lacking. And so these Black immigrant groups are typically lumped together and considered to have the same types of cultural beliefs, healthcare practice, and that is not so. Black immigrants have unique cultural and social identities, and this will affect overall their healthcare behavior as well as their cancer screening practices. So there is this gap in knowledge about the health behaviors and particularly cancer screening. And so we need to examine and do more work to identify any disparities that may exist and to address them. So when you look at cancer screening in the area that I'm from, the Caribbean basin, it's a mixture of folks from Native Americans to Europeans and ethnic Black immigrants. And the cancer screening really depends on the country in the region. In Afro-Caribbean countries such as Jamaica, there's more knowledge about cancer screening tests. Overall, the rates of cancer screening are really, really low. And there are lots of barriers to screening, such as pain, fear, discrimination, and discomfort. So again, structural barriers. When you look at this cancer screening of women from that region here in the United States, their cancer screening practices reflect basically their cancer screening experiences in their native countries. So the group of immigrant women that I'm particularly interested in are the Garifuna women. Why the Garifuna? The Garifuna represent the uniqueness of Black immigrants to the United States. They are a minority ethnic group living in Central America. The group is thought to have originated from the mixing of shipwrecked African slaves and native Arawakan Caribbean people. UNESCO, the United Nations Social and Cultural Organization, actually gave them a proclamation of intangible heritage because of their unique culture, which is a mix of African and Native American heritage. They originated from the island of St. Vincent here in the Lesser Antilles, but they were forcibly removed in the 1700s and now reside in primarily Central America on the coast in countries such as Belize, Honduras, Guatemala, and Nicaragua. Here in these countries of origin, the Garifuna live as they've lived for many years. They practice traditional lifestyles such as fishing, subsistence farming. They live in coastal villages such as you see here. They have their unique language, which is Garifuna. But in these countries that are primarily Hispanic in origin, they face structural forces such as poverty, marginalization, and discrimination. Most Garifuna, when they migrate, they have come to the United States, settling in port cities such as New York City, Louisiana, and California and Los Angeles. The number of Garifuna began to come increasingly in the 1998 as a result of Hurricane Mitch, and they settle in urban spaces such as the Bronx, Harlem, and Brownsville. And they
3 minutes remaining.
Thank you, their cultural forces. So my research focus was on whether or not Garifuna women get screened for cervical, breast, and colorectal cancer, and if they are, and also their level of knowledge about the cancer screening guidelines and perceptions of barriers to screening. So when I surveyed Garifuna women in New York, and these were the study findings, breast cancer screening rates were actually higher than the national rates here in the US, but the cervical cancer screening rates and the colorectal cancer screening rates were lower. When you look at the specific reasons, Length of time lived in the US, increased breast and colon cancer screening. Having a provider of care also significantly increased breast and cervical cancer screening, as well as having a specialist. And in terms of knowledge of the cancer screening test, there was significant knowledge for cervical and colorectal cancer screening, but they weren't adhering to the screening guidelines. So overall, there was adherence to the recommended breast cancer screening guidelines, lack of adherence to cervical cancer screening guidelines, and colorectal cancer screening guidelines, and the predictors of screening varies. And so there were similarities and differences with immigrant women from similar cultural backgrounds and geographic regions as the Garifuna. So my future work is looking at cervical cancer screening in this group, and again, looking to come up with interventions, as well as colorectal cancer screening, not only in Garifuna women, but also Garifuna men, and also opportunities to look at prostate cancer in this group. Many men from the Caribbean basin have high cancer rates. And that is the results of my study. Thank you for listening.
Thank you, Lois.
Thank you, Lois. Thanks. I'm going to keep us on this side of the Atlantic, and I'm going to go to Joni Rivera. So my colleague at the School of Communication and Information, where she's an assistant professor. Originally from Puerto Rico, Dr. Rivera's college focuses on reducing health inequities and improving well-being of Latinx and underserved communities with health communication and initiatives of various kinds. She specifically studies how engagement with health misinformation and health information, of course, on social media can impact health decisions, as well as how social media can be used to communicate with and mobilize communities before, during, and after disasters. So with that, I'm going to pass the mic over to Joni, and she's ready to go. So Joni, we're ready for you when you are.
There we go. Can you guys hear me well?
That's good.
Yeah, okay, great. Thank you so much for the invitation to be here. I'm so excited. I wish we could all be together in person, but it will happen soon enough. Like Matthew was saying, I am going to talk a little bit about some of the work that I did before I got to Rutgers. Actually, this was part of my dissertation work that was looking to understand the impact of how Latinos engage with cancer information and misinformation on social media, Facebook in particular. I want to give you guys a little bit of context on cancer health disparities among Latinos in the US. So the Latino community is actually the largest minority community in the US, and it continues to grow. And interestingly, the general US population, the leading cause of death is heart disease, but among Latinos, it's actually cancer. And we have high incidence rates of breast, colorectal, and prostate cancer among if we look at the Latino community as a whole in the US, these are also cancers that have prevention behaviors and screening tied to them, right? So it's very important to be educating people about what they can do to reduce their risk and late diagnosis of these types of cancers, because even though the incidence rates for these three cancers that I mentioned are lower than non-Hispanic whites, Hispanics and Latinos tend to be diagnosed at a later stage, right? So a lot of them aren't going to get their screenings, et cetera, for a myriad of reasons, including structural barriers. Now, this is a really big issue in the US, and especially in regards to cancer health disparities. The National Cancer Institute here have put a lot of emphasis on the importance of reaching underserved communities like the Latino community and educating them about all of these different issues and what they can do to reduce their risk of cancer. And one of the things that they have been really pushing is looking at the role that social media has to better engage with these audiences and deliver content to them that is evidence-based so they can make better informed decisions. Luckily, Latinos are on social media very avidly. And here in the US in particular, they use Facebook a lot. And with the Latino community, we see a lot of use of Facebook and WhatsApp, and we see it not just in the US, but across the board. So it's really important to understand what kind of messages related to cancer screening and prevention they're already engaging with on these platforms to develop better campaigns and educational methods for them on these different social media sites. So I just want to take a quick step and step back and explain why engagement is such an important thing when we think about social media. We know that engagement is a precursor for a lot of very important outcomes, including increasing awareness about issues, increasing knowledge about cancer prevention and screening, and ultimately behavior change, right? So when we think about engagement, I just want everyone to be on the same page. We're talking about a quality of user experience with web-based technologies, in this case, social media platforms, that enable us to interact, create, and share content with other people or other organizations, right? So with that kind of premise in mind, we see a lot of organizations taking advantage of platforms like Facebook to deliver educational content to their followers. For example, the National Cancer Institute has a Facebook page where they deliver evidence-based information. And it's great because you can monitor metrics as an organization, right? As a university or a health organization, these are places where you can kind of see how people are engaging with your content. But however, it's important to also acknowledge the environment within which this content is being placed. And that is one that has a lot of misinformation, right? And we've known from several years now within the context of political sciences that there's a lot of misinformation online. There are a lot of echo chambers and polarization. And late 2018, we started to see public health and health misinformation kind of become more of a mainstream issue, particularly with the anti-vaccine movement. And we started to see a lot of research beginning to explore what it is that we're seeing related to health misinformation online. Of course, then COVID happened, so this is all just kind of blown up, and now we are very well aware of the ramifications of health misinformation being disseminated on social media platforms. But when I was conducting this study, one of the literature that I encountered that was very interesting to me is that in 2018, the credibility of the 100 most shared health articles on social media had neutral to very low scientific credibility, right? And a lot of this was being disseminated on Facebook. 95% of the content actually had been disseminated on Facebook. But what is this looking at? This is looking at health articles only. We know that on social media platforms, we see a lot of other type of content that can be user generated, right? Someone can share a post. You don't know where that information is coming from. There's memes, videos, images, and in the case of Latinos, a lot of content in Spanish, right? So I wanted to really understand what people are actually seeing, especially people that don't have cancer, because those are the individuals that we want to target our campaigns to. Well, those are the individuals we want to go get their screenings. But what is it that they're actually encountering when they are on these different platforms? And what are we competing against? And in addition to that, of course, as a person that's in the intersection of communication and public health, it's very important for the implications of engaging with content. Like, what is that? So what actions are people taking? And it was important for me to explore a little bit of what people were doing with the information they were encountering. So these three concepts, right? Engagement, credibility of information, and action are at the core of the work that I was doing, which was exploring the reasons and the ways that Latinos without a history of cancer, ages 40 to 75, right? Because these are people that can get screened for these three types of cancers that I mentioned earlier, how they engage with cancer prevention and screening information on Facebook in particular. So I wanted to know first how and why Latino adults engage with, I call this CPSI, cancer prevention and screening information, how they assess the credibility of that information, and in what ways engagement leads to further action, if any. So I'm not gonna harp too much on my conceptual framework, but there are multiple health communication theories or communication theories that I looked at to inform the theoretical underpinnings of this work, particularly looking at uses and gratifications theory, which acknowledges that people are going to use specific media for specific purposes, right? So they're on Facebook for a reason. They get certain things out of Facebook. Among those things are the interactions that you have with your friends and family and anyone that's in your network. You're also going to see a lot of different content on these platforms, right? So you're navigating an environment where health information isn't the top priority, but it's also embedded within all of this other stuff. And then when we look at other theories like Johnson's comprehensive model for information seeking, it acknowledges that people are going to search for information when there are certain things that are important to them, when this is a salient topic. And taking those things into account, plus the importance of cultural values within Latino audiences, I wanted to really explore how it is that people are navigating this particular environment. And these are just some cultural values. I'm not going to go into detail because we don't have enough time, but we can talk about that with anyone who's interested later. So as for my study design, I wanted to take a qualitatively driven mixed methods approach to this work. Why? Well, one of the things is we know that health misinformation is an issue. I didn't want to necessarily quantify how big of an issue that is, but understand how people navigate this, right? And that really requires you to sit down with people and understand what it is that they're encountering and to explain things to you. So I had 20 one-on-one in-person encounters with Latinos in Tampa. They were of a myriad of countries of origin, levels of acculturation, et cetera. 3 minutes, thank you so much. And what I did is I sat down with people, they logged onto their Facebook account and they scrolled through content that they had seen and we discussed it. I am going to quickly go over my overarching findings and just highlight the last one in an effort to maintain to the time. So one of the main findings was that engagement with content was happening beyond people liking, commenting, or sharing. A lot of people would watch a video and then they would send it through Facebook Messenger. You wouldn't be able to capture that if you only use quantitative methods, right? So a lot of conversations around that, and a lot of people were sharing, engaging with content that had images, that was about prevention, but more from a food and diet perspective, not necessarily cancer, and shared by friends with very low credibility. The second thing that we saw is that engagement with cancer prevention and screening information and misinformation is influenced by culture. People use these, they engage with content that reminds them of their country of origin, that has their language, and things that they're able to then pull from their consciousness, like, okay, and interpret kind of the content that they're engaging with in that regard. And we also saw that sources, right, who was sharing the content was just as, if not more important than the actual content itself in engagement. We know that from the literature that it's important who is sharing, and that was very, very evident in this context. And then lastly, what I wanna share in terms of a finding example is that engagement may lead to potential harmful actions that aren't always evidence-based. So let me just scroll through here really quickly. These are just some examples of the content and the interviews that I had with people explaining the things that they engaged with. But here, this is an example of someone who engaged with a video, saw a video from a person who she thought was a physician from Puerto Rico. She was Puerto Rican. And she was highlighting how this particular person was saying that mammograms cause cancer. And it created enough, thank you. It created enough of a fear in her that she called and canceled her mammogram, right? And these are the kinds of things that when we sit down with people to discuss the content that they're actually engaging with, we get insights to. The last thing that I guess I want to highlight in this minute is that this work, as I said, this is just a little glance at it, has a lot of interdisciplinary implications. When we think about dealing with misinformation and how to develop campaigns on social media, we need to be using narratives. We need to be informing our work based on culture. We need to be identifying who those opinion leaders are in the community that can serve as a source to share the information that we're delivering, right? That they're already trusted sources. And we need to be doing interdisciplinary and multilingual transnational work, like the collaborations that we're going to be establishing with this partnership. Those things are very important, but also platform level initiatives are important. We can't just put this on the individual. These structures need to be regulated and they need to be held accountable. And as researchers, we need to be part of those conversations. So I will leave it at that. Thank you so much.
Perfect timing. Thank you.
Thank you, Joni. It was great. So, okay, so we've gone from Crete, we've come to this side to the US side for a couple of presentations. And we're going to go back to Crete and going to focus at sort of a different level, at one of our organizational level where we do see discrimination and disparities emerge. And we're going to have George Kyriatakis present for us, and I'm going to have Cleo give us a little intro to George before, as George sets up his PowerPoint on Zoom.
Yes, of course. Welcome. We have Dr. George Kyriatakis. He's an assistant professor in public health nursing, social epidemiology at the Department of Business Administration and Tourism of the Hellenic Mediterranean University. He is also faculty of the MSc program in Health Services Administration at the Hellenic Open University. George has worked as principal investigator as well as a member of research teams of various EU-funded research projects. He has published more than 35 papers in international and national peer-reviewed journals, mainly on health services research, social epidemiology, and lifestyle behavioral risk factors. Thank you very much, George, for attending our meeting. The floor is yours.
No, I thank you, Cleo, for your kind words, and thank you, and good morning and good afternoon to our participants from both sides of the Atlantic. And I'm going, of course, to present you a thing that it is very keen to my heart, and it is about the employee silence and how it is affected by the professional discrimination that nurses experience in their work. And of course, in addition to me that make the presentation, there is a research team that supports the whole project, and I have to acknowledge them. These are Irina Andriadaki, Maria Theodoropoulou, Georgios Gregoriou, and Anastasia Alvizou, our research assistants, and the faculty, Dr. Panagiotis Gorezis, Dr. Nicoleta Ratsika, and Dr. Petros Kostagiolas, that we work all together in this project. And what I would like to tell you is that to err is human. Everybody knows that. But this is not the problem. The problem is that we have to acknowledge the mistakes that we do or the errors that we do, even in healthcare, so we can we can provide better healthcare quality to our patients. But this is not the case, and I wonder why. To tell you the truth, the research is very scarce in this topic. But when there are some reports, mainly from the US, the Ireland, and the Australia, all conclude that when we have a positive practice environment, then we have less silence regarding patient safety or other issues related to the safety culture. But the main problem is not only that this research is scarce, it is that it does not pinpoint to the major underlying mechanism. And this is where we come, and we propose a very novel and unexplored concept in nursing literature, that being the professional discrimination experienced by nurses. And why is discrimination important? Why do we have to research on this topic? In this context, the problem is that, as in every kind of discrimination, the individuals internalize the external negativity, and then they modify their expectations and actions and their behaviors to adapt to the discriminatory stimuli. This means that they cannot live their personal and professional lives to the full of their potential. Discrimination in nursing has mainly been examined in the realm of minority and foreign educated nurses working in culturally diverse environments, meaning, for example, Filipino nurses or Korean nurses working in the US or Russian nurses or nurses from Russia working in Greece. But we extend this notion and we say that there is a discrimination based on the nursing profession itself. And it can be easily understood, for example, as the lack of professional autonomy, or the fact that in many countries, in many different cultures, nurses are have inferior payroll or inferior social status in relation to other female-dominated professions, such as, for example, social workers or teachers. So we define in this study the professional discrimination based on the nursing profession as a condition of structural bias in which nurses feel that they have been prevented from doing something, or have been hassled or made to feel inferior because of their nursing profession. And our hypothesis is that when we have a positive, a good, a favorable nurse practice environment, then we are going to have less professional discrimination. We are going to have less silence regarding patient safety, and that this association, the last one, will be mediated by the discrimination that nurses feel in their work. How did we do that now? It was a multi-center cross-sectional study in 7 hospitals in Greece. And the final sample that was included in this study was 607 nurses that share the typical work and sociodemographic characteristics of this group in Greece. We used 3 different tools, measurement tools, and the first one is the revised version of the well-acclaimed and extensively used practice environment scale of the nursing work index, as used in the European RN forecast study. And we measured different aspects of the nurse work environment, like, for example, participation in hospital affairs, the foundation for quality of care, the nurse managerability, and the support that leaders provide to nurses, the staffing and the resource adequacy, and the collegial nurse and physician relationships. Employee silence was explored using a 5-item scale. One of the example items is, although I had ideas for improving patient safety in my department, I did not speak up. And then to examine professional discrimination, we used the experiences of discrimination index. It was created by Krieger and her colleagues for initial use at the Cardia study to measure in racial discrimination in employment, medical care, and things like that. Then it has been adapted to very different contexts and countries and discriminations. For example, body weight, sexual orientation, disability, age, and gender. And based on that, we developed our measure, and we asked whether nurses have feelings that actually it is the definition of the discrimination that we used, and if yes, the frequency of this discrimination. And then we combined the two answers in a 5-point type scale. We did all the necessary and the right statistical analysis, mainly the process macro for SPSS with bootstraps techniques. And the main results that apply to all aspects of the nurse work environment, with the exception of the staffing and the resource adequacy, confirm our research hypothesis. And so we found that when nurses evaluated their practice environment as good, as a favorable practice environment, then they report less silence regarding patient safety. They report less discrimination, and this relationship, this association is mediated by the discrimination as it was hypothesized. Of course, there are some limitations in the study. For example, one that we have to acknowledge is that study design was cross-sectional and causality cannot be inferred. However, system-level characteristics are more likely to influence individual behaviors than vice versa. And the sample consisted mostly of Greek Caucasian women, 85%, that share very similar payroll and work-related characteristics. And so we should be very cautious when we want to generalize these results beyond this sample. However, I think that it is a strength that the sample was a bit homogeneous, and in this way, we can be more sure that that nurses did not report on other forms of discrimination that they may feel.
3 more minutes remaining.
Yes, thank you. And if I can say what's one take-home message from this presentation, that is that in order to minimize nurses' silence regarding patient safety, both the nurse work environment and the professional discrimination should be taken into consideration. And thank you for participating and see the presentation. And I'm very glad to ask any questions if you have. Thank you.
Thank you, George. Excellent timing. And I think we're doing well on timing. And I will refrain from reacting myself. And I'd like to call on our reaction panel members to kind of get us started with the discussion portion of our event. I will mention that in our reaction panel, we have Professors George Frangiadakis and Argyroula Kalaizaki and Nicoleta Ratsika from HMU. And we have Professors Pamela Rothblatt-Puglia and Charles Centeo from Rutgers. I will, once again, because I won't have time to give you a good enough preview of the great work that they do, I'm going to repost in the chat, I'll try to do it again, in the chat, the info pages for the event, which include their bios, so you can learn more about their excellent work there. And I'm going to also, before we get ahead of ourselves and move on to the conversation, we'd like to ask all of our participants to consider completing an anonymous evaluation form regarding the event after we're done or just before we're done. So I'm going to post a link for you that you can use to do that. And I'll put this in the chat as well. And for those of you that might be interested in getting a certificate of participation in our event, I know this may be important to some of our students that are here, then you will find the information on how to request that at the end of the evaluation form. Again, so your name won't be associated with the evaluation form, but you'll find the info there on how to request the certificate when you're done. Okay, so I'll turn the floor over to our reaction panel members and see who wants to give us their initial comments, reactions, since it's a reaction panel, or ask a question of any of our presenters, and I'll ask the rest of our audience to consider formulating their questions as well while any of our panel members speaks. I see a question. Well, let's see if our reaction panel has anything they'd like to share right now before I turn over to somebody else.
Sure. I thank you. This is Pamela Rothblatt-Puglia. That I just want to say that the presentations were so interesting, and I think there are so many areas that we could work together. It was very impressive. And I have several questions, but I'll stick to one as I was asked. And I just want to ask Dr. Maria Papadaki, I hope I pronounced that correctly. I'm just curious that is incredible work that you've done, and it's such a huge project, and you acted so quickly. But I am curious if I could have missed this, but I'm curious if, in addition to parenting supports in your brief interventions, if you provided supports for children, because the extreme adversity that you described with the economics, with these families, I was just curious if you also included supports for children with your brief interventions.
Thank you very much for the question, and this is very important indeed, because children are facing a lot of problems as well, and while living in multi-problematic families, they also suffer a lot of difficult circumstances and experiences. They were basically, the interventions were very brief, and the time was very limited to offer so much to all the people. But through this family interventions and through supporting parents, we realized that there were also problems with the children. So we did this referral to other agencies when necessary. And this is how we intervene in these situations related to children. Not direct intervention to children, but indirectly through referring children to different agencies, social or mental health agencies. Mm-hmm. But to tell you the truth, another thing, this gives me the floor to say another thing, that after this evidence was collected, we start another project, and this is currently also running at the moment around across Crete, our region, about learning difficulties, and we offer support to the whole family, to children that are facing learning disabilities and other developmental and mental health issues as a comorbidity, if I would say that. So this was the follow-up of the project, and it seems very interesting because, especially in remote areas, we have a lot of children's needs that are not addressed. And one of this is supporting them with learning problems and mental health issues.
Oh, wow, excellent. Amazing work. Thank you.
Thank you very much.
Thank you, Pamela. I see Nicoletta's hand up, so please go ahead.
Yes, hello. I have a question rather to Lois and your Naira. They both underline how important the culture is as concern suffer from cancer. Can they tell a bit more things about that? Why culture is so important in this disease? What did they find?
Sure, I guess I can comment first. One of the things that I really focused on in my dissertation, and because of time I didn't really expand on here, is that among the Black immigrant groups to the United States, there is a difference in culture. And the Garifuna, in a way, my case study is an example of that. The Garifuna are unique because of their historical context. They are folks that were not really enslaved, and they're a mixture of Africans, whatever tribe they were in Africa, and mixed with the native folks of the Caribbean basin. Their language is unique. It's a specific language called the Garifuna. But what's really important is that they were moved forcibly to largely Hispanic countries. And there, because they're phenotypically African, they are largely discriminated against. The unique culture of the Garifuna is really important for us to recognize because it does inform their health behaviors, as well as, again, the uniqueness of other folks that come. So my dissertation looked at acculturation and identity. One of the uniqueness about Garifuna that live in Hispanic countries is that they have tended, in order to survive, to have fluid types of identity. Sometimes it makes sense to be Garifuna, and sometimes it makes sense to have cultural norms more like the larger Hispanic culture. And so there have actually been studies that have looked at this kind of way that Garifuna have been able to survive in those countries by being fluid in terms of their identity and shifting their culture. And they do the same thing when they settle in urbanized spaces here in the United States in terms of, do they need to acculturate, or is it beneficial for them to keep the Garifuna culture? Can they identify as Hispanic, which many of them that come from Honduras and Nicaragua and Guatemala do? Or is it more beneficial for them, depending on the situation, to practice cultural norms that are more Afro-Caribbean-like? So that is why they're such an interesting group, is because of the fluidity in which they are able to use their culture in order to survive.
Yeah. So in regards to my work, Nicoleta, one of the bigger findings that I saw, that I briefly mentioned, is that when my participants were engaging with content and making sense of it and determining, which I didn't get into, the credibility of it, right? Like, how do you know this is accurate? What's your process? Culture and that cultural identity was really underlying a lot of the sense making that people were articulating. And I didn't get to show this example, but there was one post in particular that emerged in several of my interviews, and it was a picture and a video of soursop or guanábana, which is a fruit that's very typical in the Caribbean and in South and Central America, that has been attributed medicinal properties, including like cancer curative properties. And a lot of different participants would comment on, oh, that's from my country. I know that fruit. The stories in my country were X, Y, and Z, right? So there was this like understanding of a lot of the content and making sense of, oh yeah, well, this makes sense. I've heard it before. My grandma would talk about it, tapping into that portion. But then the other thing that I think is very important is, even though these cultural values that I had on the slide, right, like the role of family, the role of these trusted sources, or the people that you trust in your community, those very strong bonds with friends and family, they're obviously not unique to the Latino community, but they are part of this collective kind of worldview. And a lot of the content that people were engaging with was coming from these people that they already trusted blindly for a myriad of reasons, right? And again, that's really, when we're thinking of, well, how are people engaging with and interpreting misinformation, which might make it even harder for us to correct, taking into account those cultural values and norms and elements of cultural identity are very important. But then also on the flip side, if we're going to be designing and delivering content, we need to be thinking a little more creatively about how we incorporate these different elements of people's culture, which we do in health in communication, right? Like, we know that it's important to culturally tailor your materials, but when we think about online, where everything is happening so fast and people aren't necessarily on Facebook to learn about cancer, right? They're going through more of a peripheral, like quick visual cues and other inferences to make sense of whether or not something is worth engaging with and if it's credible. So we need to be tapping into, how do we design content that's evidence-based, that is also triggering those things from a cultural lens. But yeah, we can get into that.
Thank you very much. It's a big discussion, I'm sure. Thank you.
Thank you for the question, Nicoleta, and for the responses from Lois and Joni. Anybody else from our reaction panel that wants to comment now or ask a question? Okay, so I'll go to our audience. Oh, I had one hand up. There we go. I'm not sure if I have this name correct. Apologies if I mispronounce it. So Fatjona Camberry has a question.
Yes, hello everyone. I'm Fatjona, I'm from Albania, University of Law, Faculty of Health. And I have a question for Mr. Christotakis. First of all, thank you for sharing such a sensitive topic, such as professional discrimination in nursing. And based on your opinion and research, the situation created by the pandemic has affected the perception that nurses themselves have about their status, because the phenomena of nursing bullying that begins even before nursing education, with the choice of nursing profession and continues throughout the profession career, whatever I choose to be in clinical practice or as an academic. So based on your opinion and research, has affected this perception, the perception and the image that nurses have for themselves, and also the image that they have in the society, because the nursing profession grow out of a need within society and continues to evolve based on the needs of society. Thank you.
Thank you, Fatjona. Thank you for participating. It is very nice to meet you after so long, because it's been
It's a long time.
5-6 years we've met. And what I would like to say is that if you have understood, I was a bit stressed earlier, and although I had my 12 minutes, I did not use them. So I hope that I did not miss any very crucial information. Sorry for that. In terms of what Fatjona has asked, what we researched is not the views that nurses have for themselves, but what they think that others think of themselves, and if they have lost any, for example, any crucial professional development, and if they lack professional autonomy, and if they feel that their social status, not their self-respect, is low or lower than other professions in a specific context. And so our approach was a sociological one. And it has nothing to do with the lateral violence or the bullying that can be measured or can be found inside the hospitals. In terms of the pandemic, to tell you the truth, I don't know yet, because we are still in the pandemic, and I don't know if the perceptions, the social perceptions of the nursing profession are ameliorated or not yet. I think that we will be able to tell it in 1 or 2 years after all this pandemic has started to be behind us, and things are going to be normal. Right now, I think that my main concern is that nurses are thought as heroes, but they are not thought as scientists. They are not thought of as autonomous professionals. So I would prefer to be a scientist and an autonomous professional and be able to do things by myself than be a hero. Then we will see. With your question, now we have to repeat our this specific, research, this specific study. Thank you.
Thank you very much.
Thank you for the question and George's response. Do we have other questions from our audience about any of the presentations that we've heard? I saw some discussion in the chat, but is anyone that wants to speak and share a question or a comment about anything they've heard up until now.
I have another question, if that's okay.
Yeah, go ahead.
Okay, thank you. Yoni, this is a question for you. I'm just curious. Yeah, you mentioned, in messaging, and I think this actually relates to a lot of these projects. The health communication piece is so important and nuanced. And you mentioned cultural resonance, as a way to help reach, engage people. And I'm just curious if you've ever looked at, in addition to, other frame resonance, other factors that, like, for example, attribution, how things are attributed, how blame is attributed. Like, for example, like with obesity, very often it's, even though we know it's complex and it's not just individual behavior, a lot of the messaging around obesity is actually blame-based, or lung cancer is another one, or HIV/AIDS is another one. And so I'm just curious, in your work, have you looked at attribution theory? Have you used attribution theory to look at how people resonate with messages, to see, because I think there's some data to show that if it's attributed to a larger societal issue, people are more likely to take action than if it's attributed in a blaming way. And I'm just, can you comment upon that in your work?
Yeah, well, so thanks for that question, Pamela. I haven't looked at that. However, like I mentioned, the work that this particular, exploratory pilot kind of study was looking at individuals that don't have cancer, right? So the salience of a lot of the content that we were discussing was, in part, I think that attributes to the fact that a lot of people weren't engaging with screening stuff or actual cancer prevention messaging versus food and diet messages that happen to also say this cures cancer, but they were interpreting it with a different lens. Like, well, maybe it doesn't cure, but it's food, so it won't harm me. The next phase of my work, which will start later this summer, is actually looking at how cancer survivors, caregivers, advocates, people that are a lot more embedded in the cancer continuum, are navigating this kind of content on these platforms. Not just Facebook, also WhatsApp and Facebook Messenger, because that was something else that I saw in my findings, that there's a lot of inter-platform connectivity that we need to take into account, because that's how people are sharing and amplifying messages. I do think that I might be seeing some of that you're mentioning, especially messages related to guilt or anything like that we see, with like fatalism and cancer. There's a lot of literature that looks that shows that fatalistic views can be detrimental, but also be good, right? Because people may say, well, God is in control, but God gave physicians these skill sets, so let me go to the doctor and get my screening done, right? The other thing that I think I will see, because I saw this tangentially in this work, there were a lot of content that was shared that had more to do with like survivorship, right? Not a lot of prevention or screens, but stories and survivorship things that again appeal to that like fear or guilt that people might have, but also the sense of bonding and trust that you have by supporting cancer survivors and their stories and their narratives. So I think this is a great idea. I would love to talk more to you about this later as I kind of delve into that. But yes, those are really important things, and especially doing so from a cultural lens of understanding what those different types of framing really mean to people and how they interpret and how we can leverage that in messaging.
Thank you.
Great. Okay. Unless we have any other comments, I'm aware of the time that we reached the end of the allotted time. If anybody has any additional comments, please raise your hand. In the meantime, I should say that we seem to, we've covered this kind of a brief introduction to some very different topics from both sides of the Atlantic. There are some common themes and interests that emerge from this discussion. I mean, we've talked to some extent about disparities that are related to socioeconomic status, related to culture and ethnic and racial background. We've talked about interventions to address such disparities to some extent. And we've sort of taken the discussion one level up and began to explore the role that professionals, like for example, nurses working within healthcare facilities can play to address disparities in that workplace, but also how their roles may be hindered, or how may they be kept back from performing this crucial function by how they're perceived by colleagues or other professionals in the workplace. So we can take the discussion in several different ways, several different directions, which we won't be able to do right now in the context of this discussion, but we'll take all the comments and feedback that has been shared sort of in discussion, but also in the chat. And a smaller group of us will be meeting after this event is over from both sides, and in an effort to kind of reflect on what went on this morning and figure out ways in which we might continue the conversation in upcoming events and activities. So if you are interested in knowing more about what we're up to and what we will be up to in the coming months, do contact us. We'll soon have a website up to share some of this information, and we'll share that with everybody that has registered for the event as well. But in the meantime, unless there's anything else that anyone's mind in the room, I will thank you all for coming out this morning and this afternoon to join us. And we look forward to seeing you in a following event, probably this coming fall. In the meantime, stay well, stay safe and healthy, and I hope you get to enjoy the summer a little bit as well. Take care, everyone. Bye-bye.
And thank you, Matthew
everyone.
and Riva,
Thank
for
you.
organizing and leading this event.
Thank you,
Thank you very
Daphne.
much.
Thank you.
Thank you, Daphne. Thank you for your support.
Bye.
Bye-bye.
See you
Bye, everybody.